Hello friends, Namaskar, I'm Dr. Mukhmohit saying this is INICET 2022 PSM booster in the video version. From past so many days I had been constantly receiving a lot of DMs from students as appearing for this next week INICET exam, that what are the last minute revision points. So these are just 20 points beta I am forwarding to you. You just see these points and make sure that you know tick 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 tick, yes I know these, yes I know I don't know this. If you don't know this, let us move ahead and take just a very quick review about what all things I would remember before I go for the INICET exam. One is meta-analysis. Meta-analysis is a favorite question of the examiners. Meta-analysis, beta, it is a statistical approach. It is a type of evidence-based medicine, and it involves statistical approach. There is a median of the medians. So you take different studies and you study the median of the median, and you make something called as forest plot. In your exam, they may ask you how to interpret a forest plot. You already know that we know that there is something called as risk ratios or the relative risk, or we have the odds ratio. So what we do in forest plot is we draw the median of the medians of the relative risk or the odds ratio. You know that the relative risk or the odds ratio, if they equal to 1, it means what? It means no association. So what you see over here is you see different study designs. You have study number 1, 2, 3, 4, 5, and this was their median effect. And the median of the median effect, that is given by this symbol, which is called as a rhombus or a diamond. So the diamond symbol, it gives the median of the median. So where does this median lie? The median of the median, it lies more than one number. So that means that there is a higher risk for males. That means the males had a higher risk for admission to ICU in COVID-19 patients. This is what is the interpretation of forest plot. What you see over here is forest plot. It is drawn in meta-analysis. Topic number 2. What do you mean by publication bias? Publication bias is where some set pattern of the researches are being published by various journals because they are of more interest to the publication committees or to the researchers or to the people at large. So technically it is said that whenever there is publication, whenever the research is being conducted, it should always be symmetrical. How do you find out symmetry? You just make something called as forest plot. What you see on the screen is forest plot. So the dots, these small dots, they denote the results of the studies. So ideally the results of the study should be symmetrical. They should be equal on left and right side. In case there is asymmetry, in case there is more asymmetry, that means there is some sort of publication bias. Topic number 3. You already know that there is something called as primordial prevention, primary, secondary, tertiary prevention. What is this quaternary prevention? Quaternary prevention is, nowadays it's not linked to that primary, secondary, tertiary prevention. Quaternary prevention is where you overdiagnose people, or you try to find disease very aggressively and you overdiagnose at a very subtle level, which may not be of the benefit to the patient at that particular time. So it does more harm rather than good. Overestimation or overdiagnosing of a condition is given a technical specific name, that is called as quaternary prevention. Topic number 4. What are ecological studies? Ecological studies, they are type of the analytical studies, and they are kind of a weaker study designs compared to the case control or to the cohort studies. The ecological studies, 4 points for you to learn, that they are correlational studies and they use third party data to correlate variables. I would like to remember this point. They use the third party data to correlate the variables. The unit of study is a total population. This has been asked millions of times. It's a very Gisawa MCQ, and it is related to ecological fallacy. That is the bias that you see in the ecological studies, and it is a weaker type of study design. It is type of analytical study. What is this nested case control? Beta, nested case control is a type of a cohort study design. So although the name says nested case control, but in actuality, it's not a case control. It is a cohort study design. It is the study of choice for rare risk for rare investigations, and for expensive investigations, and for rare investigations, the study of choice is a nested case control. A very quick review about epidemiology, very frequently asked in your INICET exam. We already know there are 2 broad branches. Either we can have observational studies, or we can have something called as experimental studies, and there is third branch that is kind of technically different, that is evidence-based medicine. Observation studies, beta, it can be descriptive or it can be analytical. Descriptive studies are used for hypothesis formulation, whereas the analytical studies, they are used for hypothesis testing. The experimental designs or the evidence-based medicine, they are used for hypothesis validation. Where do you find odds ratio? Odds ratio can, if you get the single best answer, odds ratio can be found out in a case control study. But yes, it can also be found out. We can also take out the odds ratio in a cross section study, but of course not. No odds ratio can be found out in a cohort study. In cohort study, what do we find out? In cohort study, we find out the relative risk, attributable risk, or the population attributable risk. You should know the formulas of these. These may be asked to you in your exam, but generally speaking, nowadays you don't have that pen and paper type of numerical solving exam, so I doubt they'll ask you to calculate odds, attributable risk or the population arm, but at least you should know the formulas. Next is, what is the study outcome? Cohort studies has been the question of choice by the examiner. It is the study. Cohort studies, please remember, is the study which gives you the incidence. Cohort study is the study which helps you learn the natural course of disease, and cohort study helps you establish temporal association. What do you mean by temporal association? That means the risk factor is preceding the disease. That means the risk factor is before the disease. That is what is cohort studies, and that is what do you mean by temporal association. The experimental study designs can be randomized or non-randomized trials. What do you mean by randomization? Randomization means known and equal chance, and randomization helps remove selection bias, whereas randomization is done while the time of allocation. So randomized trials could be clinical trials, could be preventive trials, risk factor trials, and so on, but the non-randomized are pre-post study designs, or we can have disasters or natural experiments. In experimental designs, what do we calculate? We calculate something called as number needed to treat or number needed to harm. This is also MCQ exam. It has been asked a lot of times how to calculate the number needed to treat. It is super easy. I'll be taking up this point in forthcoming slides. Evidence-based medicine, we have already talked that meta-analysis, it is one of the best measures, because you can find out a statistical approach. You can find out the median of the medians and say that yes, this is the risk factor. It is the strongest design to establish causality. But many times I've seen the MCQ that they'll give you options from the observation study design. Within the observation study design, which one is the strongest? It is cohort study. Out of all the study design that you see over here, which one is the strongest? It is meta-analysis. So now coming over to this concept of what is number needed to treat, we can take a simple example. 100 people were given a particular novel drug, out of which 5 people developed fatal leukopenia, and 500 patients were receiving the conventional standard treatment for the cancer, out of which 50 people developed the complication. How many patients should receive the new drug in order to prevent one case of fatal leukopenia? That that concept is what is called as number needed to treat, and this has been fancy question, and it has been asked in INICET exam, previous year exams. So what you can do is you can make a simple table out of it. You in your mind only, you can make a simple table that 5 out of 100 are in the exposed group, whereas in the non-exposed group or in the control group, 50 out of 500 are there. So beta, first things you have to calculate is something called as control event rate, or we calculate the experimental event rate. How do you calculate the control event rate? That is, in the control group, how many people got the event out of the total? That is 50 people out of 500. 50 over 500, that is 0.1. Experimental event rate. In the experimental group, which one is the experimental group? That is 5 out of 100. So 5 out of 100 got the event, that is 0.05. Now once you calculate the control group, experimental group event rates, now you are eligible to calculate the relative risk reduction, absolute risk reduction, relative risk, and the number needed to treat. How do you calculate the absolute risk reduction? It is simple. That is CER, control event rate, minus the experimental event rate. So very simple, it is 0.1 minus 0.05. Answer is 0.05. So this is very important to calculate absolute risk reduction. Please note, it is not the relative risk reduction. How do you find out the relative risk reduction? Relative risk reduction is nothing but CER minus the EER, that is the absolute risk reduction, over CER. That is 0.05 divided by 0.1, which comes out to be again 0.5%, which is like 5%. That is what is the relative risk reduction. The number needed to treat is given by 1 over absolute risk reduction, that is the ARR. So that is 1 over 0.05, which would come out to be 20. So you need to treat 20 patients in order to save 1% from fatal leukopenia as a complication. What do you mean by relative risk? Relative risk is also called as the risk ratio. It is also called as the risk ratio. It is the event rate or the incidence or the risk in the exposed group, event in the exposed group, that is the exposed group event rate, divided by the event in the non-exposed group. That is what is 0. In the exposed group, in the experimental group it was 0.05. 0.05 divided by 0.1, that is what is 0.5. So we know that the relative risk is less than 1, that is 0.5. That means it was protective. That means the drug was protective for this particular event, that is fatal leukopenia. Anyways, very frequently they have asked you how to calculate the number needed to treat. So how do you do that? You simply take the absolute risk reduction and divide it by 1, and that is what is the number needed to treat. Point number 2, you should know what is standardization. Beta, standardization can be of two types. We can have something called as direct, or we can have indirect standardization. In the direct standardization, listen very carefully, in the direct standardization, we know the age specific death rates of the population for which you want to compare. If you know the age specific death rates, you do direct standardization. Whereas in certain scenarios, if the age specific death rates are not available, in case they are not available of the population for which you want to compare, and you don't have the age specific death rates, in those cases you do indirect standardization. And in indirect standardization, you calculate standardized mortality ratio. What is standardized mortality ratio? It is the ratio of the observed deaths divided by the expected deaths and multiplied by 100. That is what is the SMR, or the standardized mortality ratio. Next is topic number 6, a very quick review, crash review about the national immunization schedule. So that is what is the ultra flash. So here you can see a small child, and on the child you can have the left side or the right side. So what are the vaccines you're going to give on the left upper arm? This one is the left upper arm. In the left upper arm, beta, we are giving BCG and Japanese encephalitis. BCG is always given as intradermal, whereas Japanese encephalitis is always given as subcutaneous. Japanese encephalitis is a live vaccine that we are using. It is a live vaccine, and Japanese encephalitis is reconstituted with a special buffer that is called as the phosphate buffer. The BCG vaccine, what we are doing in India is a direct BCG vaccine. That is, we are not testing the child that whether the TST is positive or negative. We directly give the BCG. And BCG, if the dose is asked for age less than 1 month, the dose is 0.01, 0.05. Otherwise, the dose is standard 0.1 ml given as intradermal. In the right upper arm, on the right hand side, in the right upper arm, the vaccines that we are giving is the fractional IPV and the measles rubella. Measles rubella vaccine has been asked a lot of times in the exam. Measles rubella vaccine is 0.5 ml. It is given as subcutaneous injection, and it is a live vaccine. Measles rubella vaccine is given at 9 months, first dose, and the second dose is given at 16 to 24 months. There is only one important MCQ, that is the side effect of the measles rubella. That is a measles-like rash which can happen any day after 5 to 6 days till 10 days. So it is a self-limiting. The rash will happen and it goes off within 2 to 3 days. It doesn't cause any harm, and that is the only side effect. Fractional IPV dose is 0.1 ml intradermal. So what you see on the left side, one subcutaneous, one intradermal. On the right hand side, again one subcutaneous and one intradermal. On the legs, beta, we have the PCV injection, that is the pneumococcal conjugate vaccine, which is given in the right anterolateral thigh. In the right anterolateral thigh, whereas on the left hand side, left anterolateral thigh, we have the pentavalent vaccine, the DPT, and the hepatitis B. Hepatitis B has been asked again and again in the exam. What is the use of hepatitis B? Does it prevent hepatitis B in the child? No, it does not prevent hepatitis B in the future of the child. It only prevents the mother to child transmission of hepatitis B. It inhibits the MTCT, mother to child transmission of the hepatitis B virus, in case it happens during perinatal period. And that is the reason the hepatitis B vaccine is only given within 24 hours of birth. If the child is reporting late after 24 hours, no need of giving the hepatitis B vaccine. Oral polio vaccine and rotavirus vaccine, they both are oral vaccines. Oral polio vaccine is a live vaccine. It is given in dose of 2 drops, and the side effect of oral polio vaccine is a vaccine associated paralytic polio. There are two types of VAPs. Vaccine associated paralytic polio could be a contact VAP, or it could be a recipient VAP. What do you mean by a recipient VAP? Where the child who got the acute flaccid paralysis, they themselves received the OPV. What do you mean by contact VAP? Where the child got AFP and he or she did not take the polio vaccine. Their brother or their very close friend took the polio vaccine, and because they shed the vaccine in the stool, this child got the vaccine associated paralytic polio, that is a contact VAP. So there are two types of VAPs. These are the side effects of the polio vaccine. Oral polio vaccine, that is the Sabin vaccine. Rotavirus vaccine, that is a 5 drops. It is given orally, and the side effect of rotavirus is intersusception. Rotavirus vaccine can be given till 1 year of age. Oral polio vaccine can be given till 5 years of age. A lot of questions come on the cold chain mechanism. Please note that which vaccine is the most heat sensitive. The most heat sensitive, you're going to mark only one answer, that is the oral polio vaccine. Oral polio vaccine is one of the most heat sensitive, but in your exam, if the examiner troubles you regarding the reconstituted BCG vaccine, the reconstituted BCG, once you reconstitute the BCG vaccine, the reconstituted BCG vaccine is more heat sensitive compared to the OPV and compared to the measles vaccine. Which vaccine is the most freeze sensitive? Direct answer is hepatitis B. This can be MCQ, that which vaccine is both heat and freeze sensitive. It is both slightly heat sensitive and also freeze sensitive. Rotavirus and the influenza inactivated vaccines, mostly they'll ask you about the rotavirus vaccine. Next, they can also ask you which is the vaccine which is stored in the middle compartment of the ILR. The middle compartment of the ILR will always store the TT vaccine, the TD vaccine, and the rotavirus vaccine. They are always in the middle part. Which vaccine is in the top shelf? The top shelf will always store the hepatitis B and the pentavalent vaccines. Which vaccine is in the lower shelf? The lower shelf will always, the lowest will always be the oral polio vaccine, and above that is the measles vaccine. Next is, they can also ask you which vaccine is not under open vial policy. Usually it is said that if you open a vaccine, it should be used within 28 days. So 28 days is the landmark answer. But which vaccine cannot be stored till 28 days? These are the vaccines which are not under the open vial policy, and these vaccines are the Japanese encephalitis, BCG, measles, rubella, and the rotavirus and the COVID-19 vaccine. These are not under open vial policy. A very crash review about the biomedical waste management. You already know there are 4 categories: yellow category, red category, blue category, and white category. Please remember that the cytotoxic, very direct MCQs I'm going to talk, cytotoxic drugs and the expired drugs, they all go into the yellow D category. Yellow D, remember it by heart. All the blood bags, blood samples, vacutainers with blood, anything which is with blood will go into the yellow category. Now, when I say anything with the blood, do not take into account gloves. Whatever happens, gloves, whatever type of gloves you know, gloves with the blood, without blood, any type of glove have to go into the red category. Please do not get confused. Gloves do not go into the yellow category. So this, I'm talking about the general biomedical waste mechanism guideline 2020, amendment 2020, BMW guidelines 2016. I would also like to reinforce over here that the X-ray developer fluid, infectious fluid, and the chemical waste fluids from floor cleaning disinfectants or the floor clean or the antiseptic lotions, that whatever is discarded in the hospital, all these come under the yellow F category. So yellow is a very kind of a risky category for your MCQ exam. Make sure you know these 8 categories. You have the human waste, animal waste, soiled waste, anything which is cotton, gauze. I would also like to tell you that plaster and cast, they are in the solid waste, yellow C category. Discarded medicine, including the cytotoxic waste, chemical waste, liquid chemical waste, which is the X-ray developer, the insecticide, pesticides, and the body fluids, they all go into the yellow F category. Yellow G is bedding, and yellow H is microbiological laboratory biotechnology, including the blood bags and all these things. What about the sharps? Sharps, they always go into the white category. All types of sharps, they go into the white category, which includes syringes with needles, lumbar puncture needles, suture needles, and broken glass. Please note, glass will always go into the blue category. A lot of times they have asked you about the orthopedic implants. Orthopedic implants is blue category. Controversies arise when they ask you about vacutainers. Please note that vacutainers are in the red category, but if they ask you vacutainer with blood, that goes into the yellow category. Blood bags, they always go into the yellow category. Urine bags, they always go into the red category. Very important, frequently asked, what about the intrauterine devices? Please note that the intrauterine devices is considered as a soiled waste, and it is discarded in the yellow category and not in the red or in the blue or in the white category. Next is point number 8, measles, chickenpox prevention, very high yield topic. So in case there is a child reporting to the OPD with varicella, what do we do with the contacts in case they are susceptible? So varicella vaccine is the best answer. Varicella vaccine can be given to exposed contacts within how much time? It should be given within 5 days of exposure. Otherwise, and sometimes, because varicella vaccine is a live vaccine, that is the OK strain vaccine, we can also give, if the varicella vaccine is not possible to be given because the female is pregnant or if the child is immunocompromised, we can also give the varicella zoster immunoglobulin, which is given at the dose of 12.5 international units per kg body weight, max of 625 international units, to be given within how much time? Within 72 hours of exposure. Please note that the varicella zoster immunoglobulin should never be combined with the varicella vaccine, because the vaccine will make the zoster immunoglobulin non-potent and both they will not act together. So there should always be a gap of 4 to 6 weeks between the varicella zoster immunoglobulin and the varicella vaccine. Coming over to next high yield point about the measles vaccine. Measles vaccine, you already know, measles rubella. Just now we talked measles rubella given at 9 months first dose and at 16-24 months second dose. When do you give the measles containing vaccine? 0 dose. Please note that the 0 dose can be given in cases of outbreaks. This measles containing vaccine can be given in the age group of 6 to 8 months only. So it is given only after 6 months of age, but before 9 months of age. In this age group, you give the measles containing vaccine 0 dose. Next question can be asked that if a child had already received the measles containing vaccine 0 dose, what about the measles rubella first dose? Do you still need to give to the child? Answer is yes. Please note, containing vaccine 0 dose, it's an additional dose you give. Very nice. You don't give, that's okay. At least give the measles rubella first dose. Measles containing vaccine can also be given to the contacts in case of suspected exposure. This was the MCQ which was asked in the last NEET exam also. Measles containing vaccine can be given to contacts within how many days? It should be given within 3 to 4 days. Dose is 0.5 ml. Just now we talked, given as subcutaneous. It contains more than 1000 viral infective units, and the antibiotic which can be used is neomycin. Neomycin is the antibiotic which is included inside the measles vial. Please note that the measles vial is a heat and light sensitive vial, and that is the reason the measles rubella vial is a brown colored vial, because amber colored vial, because it is light sensitive. Once you reconstitute measles with water, measles with distilled water. So once you reconstitute, it should be used within 4 to 6 hours. So you should also know that in certain situations where the measles vaccine cannot be given to prevent measles, we can give the measles immunoglobulin, which is given at the dose of 0.25 ml per kg body weight, measles immunoglobulin, which is given within 3 to 4 days. It is given within 3 to 4 days, and followed by this we can give the measles vaccine 8 to 12 weeks later. Please note, measles vaccine is also never combined with the measles immunoglobulin. Another point is that the measles vaccine, the vaccine for measles, it should not be given to people who have received some immunoglobulins. Roughly, specifically talking about hepatitis A immunoglobulin. If the child has received any immunoglobulin, specifically talking, if the question says hepatitis A, then it is 3 to 6 months of gap you need. You need a minimum of 3 to 6 months of gap for giving the measles vaccine in case of previously administered immunoglobulin to the child. The vaccine effect, when does it start? The effect of the vaccine will start after 10 to 12 days. So these are a couple of MCQs which are asked on measles and chickenpox. Next is rabies and tetanus. Rabies, we have four types of exposure regimes: re, pre, thi, and SN. Please note that the number of alphabets, the number of letters which are there in re, 2, that is 2 visits. Pre is 3 visits, 3 alphabets, 3 letters. Thi is 4, THAI, 4 letters, 4 visits. SN, ESSEN, 5 visits and 5 alphabets. So just remember, the number of visits is the number of alphabets. How many doses? It is 2 doses, 2 visits, 3 doses, 3 visits. Please note that Thai Red Cross regime is given as 8 doses. It is a 2 site per visit. It is given on 2 sites per visit to 0.1 and 0.1 ml. SN regime is intramuscular. It is 5 visits and 5 sites. So these both are the post exposure prophylaxis. When do you give the re-exposure? Re-exposure is given in all cases of pre-exposure, all cases of pre, and if the post-exposure prophylaxis was taken more than 3 months ago, in those cases we are going to give the re-exposure prophylaxis. Next is talking about the tetanus toxoid. Tetanus toxoid, we can have category A, B, C, D. A is within 5 years if the patient has taken complete TT. 5 to 10 years, more than 10 years. If within 5 years, you don't need to do anything. If 5 to 10 years, then you need to give 1 TT shot. If more than 10 years, now if the wound was clean and if it comes within 6 hours, if it reports within 6 hours and the wound was clean, then you simply need to give 1 TT booster. But if the wound was more than 6 hours ago, or if it was an unclean, you need to give the TT booster with the tetanus immunoglobulin. And of course, in never immunize, you need to give both the primary dose of TT and tetanus immunoglobulin if the wound was contaminated or if it was more than 6 hours ago. Coming over to the next very high yield topic about COVID vaccines. You already know that Covishield. What is Covishield? It is a viral vector vaccine and it is from the AstraZeneca or the Ch.pox1 strain. What is Ch.pox1? That is the chimpanzee adenovirus Oxford 1 strain. So Covishield has been used in India. It is a viral vector vaccine. Covaxin is a killed vaccine, inactivated vaccine. Covaxin and Sinovac, these are the only two killed vaccine which have been used in many parts in the world. Covaxin has been more commonly used. Sinovac or the Coronavac has also been used, but of course it was manufactured from China. Sputnik is from Russia Gamaleya Institute, and Sputnik or Sputnik is also a viral vector vaccine. Similarly, Johnson & Johnson is also a viral vector vaccine. Novavax is a protein subunit vaccine. Pfizer and Moderna, these are the mRNA vaccine. Coming over to the latest update in the COVID-19, we have two vaccines, Corbevax and Incovac. Corbevax is a receptor binding domain vaccine, RBD. It is a recombinant subunit protein vaccine. It was manufactured in India by BE Biologicals, and it is given for age group 12 to 14 years, 0.5 ml intramuscular injection. Incovac, it is the most recently, it has been given a go-ahead by the DGCI for that is the Director Controller General of India, Drug Controller General of India, and it is the first nasal vaccine, Incovac. It is again a viral vectored vaccine which uses an incompetent or a replication defective adenovirus. It is approved for age more than 18 years. It is given in 2 doses and it is a nasal vaccine, Incovac. Coming to the next point, that is a burning topic for public health in India, that is typhoid prevention and antibiotic resistance. It is sad affair to say that India, Vietnam, Pakistan, these are the few countries, and few countries in Africa also, these are the few countries which have these are the only few countries which have reported the MDR resistance in typhoid. So we have something called as whole genome sequencing for typhoid, and this has been carried out in many states and many cities in our country, in India also. We found out that what is MDR typhoid, that is resistance to chloramphenicol, trimethoprim, sulfamethoxazole and ampicillin. Fluoroquinolone resistant Typhoid can also be there. We can also have cephalosporin resistant, azithromycin, and extensively drug resistant. So when do you classify a typhoid as XDR typhoid? XDR typhoid is when there is all the first line antibiotics, that is the MDR, plus fluoroquinolone, plus third generation cephalosporins, that is called as XDR for typhoid. Very recently, the DCGI is also thinking over introducing a newer type of vaccine, that is the typhoid conjugate vaccine. I know in my lectures in the classes we have already discussed about the typhi 21A and the VI polysaccharide vaccine, which are earlier given. But now government is also thinking about the type bar TCV, that is a typhoid conjugate vaccine, which is to be introduced after 6 months of age. It is the advantage of typhoid conjugate vaccine. It is given only as a single dose, and the duration of protection is kind of like 2 years. But still, the efficacy trials are still not the efficacy, the effect or the longevity of the effect trials are still underway for the TCV, but TCV is one vaccine which you should be knowing. Coming over to the next point, point number 12, that is the air quality index. If you talk about the air quality index, it can be graded in 0 to 50, 50, 100. Just I don't want you to remember each and every classification or the category, but at least you should know less than 100 is okay types. Less than 50 is pretty good, common sense, but less than 100 is kind of okay, tolerable, and anything which is more than 300 is not okay. It is very poor or severe air quality. Please note that the air quality index is under the Center for Pollution Control Board by the Ministry of Forest and Climatic Change and Environment, and it includes 8 air pollutants. Which are the 8 air pollutants? That is the particulate matter number 10, 2.5, ozone, sulfur dioxide, nitrogen dioxide, carbon monoxide, lead, and ammonia gases air quality index. Point number 13, make sure that you do a tick mark about the adverse events. It's a very simple topic, just 5 points for you to remember. How many types of AEFI do we know? AEFI, that is the adverse events following immunization. Product related, quality, immunization, anxiety, or coincidental. Product means that is the vaccine which you were giving that only had that problem. So that is the inherent problem. So for DPT, you already know that there is unconsolable cry and there could be neurological deficits. It is a product related AEFI. Quality related is where the vaccine was manufactured because of some malpractices or there was some problem in the manufacturing. The quality of the vaccine was defective. So that is kind of the manufacturer's problem. It is taken very seriously by the government of India, quality related AEFIs. Next is the most common errors which can happen in the program is the immunization errors. It was earlier called as the programmatic errors, but now we have changed the name to immunization errors. Immunization errors mean the people who are giving immunization, they are not properly trained, or you're not able to handle the vaccine with the cold chain. There is improper handling or administration. It is largely preventable. Government of India takes this also very, very seriously, and this is one of the most common AEFIs in our country. Anxiety related and coincidental. Of course, anxiety is whenever you get a COVID injection, you of course get an anxiety. What is going to happen next? And coincidental is you got the infection and you got the vaccine, and next day you met someone with flu and you got sneezing and runny nose, and you say this is due to the vaccine. That is coincidental. The AEFIs can also be classified into 3 types. We can have the minor, severe, and the serious AEFI. There's nothing called as the moderate AEFI. So severe is where the disability and rarely life-threatening, but there is kind of temporary disability. But if the disability becomes permanent, it is a serious adverse event following immunization. Coming over to the next high-yield, very burning topic, global problem, WHO. WHO, you should know that WHO formulated on 7th of April, that is the World Health Day, in the year 1948, headquarters in Geneva, Switzerland. It has 34-member executive board with 194 member states. So they keep on shuffling, and 1/3 of the board members are renewed every term. What I would like you to remember is the WHO regions. How many WHO regions we have? 6 WHO regions. These 6 WHO regions are the Southeast Asia, the Africa, America, Europe, Eastern Mediterranean, which is different from the Central Asia or from the Asian countries, and Western Pacific is again different. Western Pacific has the headquarters where? Not in Australia. It has the headquarters in Philippines. Please note, Eastern Mediterranean does not have this the headquarters in anywhere else. Like, don't think about Afghanistan and Pakistan and all those countries. Think about Egypt, Eastern Mediterranean. Europe, I think everybody knows it's in Copenhagen, Denmark. America is in Washington. Africa is in Brazzaville. Congo and Southeast Asia is in India. So this has been a lot of times this has been asked, anything which happens to the child in our country. Child is under 5 mortality rates, global hunger indices, urban child health rates, rural health, anything like nutrition of the children, school going children, everything is funded by the United Nations, UNICEF, right? So please note that the family planning program is funded by the USAIDs. Very commonly, they have asked about the NIHAE, that is the National Institute of Health Administration and Education, which is located in Delhi, that is funded by the Ford Foundation. Next is, a lot of times they have asked about the AIMS, not the AIMS, AIPH, that is the All India Institute of Hygiene and Public Health, which is in Kolkata. It is funded under the Rockefeller Foundation. It is funded by the Rockefeller Foundation. So Indian Red Cross is for all the disasters, and a lot of times they ask you questions from this. This is also another important topic. Point number 15, bioterrorism agents. They can be categorized into category A, B, and C. Category A are the bioterrorism agent, which you already know. So these are the agents which are going to cause very high level of mortality, and they have a major public health impact, and these are the agents which we already know. So they pose imminent risk to the national security. Category A. Category B are also the bioterrorism agents, the bacteria or the virus or the fungi or the parasites, whatever. But they are kind of moderately easy. They do cause some disease, but they don't cause very high death rates. But yes, they are a menace for the system. So we know about agents in category A and B. Category A is very aggressive. Category B is kind of low. Category C is, just think on these very importantly, ease of production and dissemination. These are some viruses which you can produce, and they have a potential for high morbidity and mortality. So they could be engineered for mass dissemination in the future. These are the category C agents. So they can ask you which agents can fall into it, each of them. So please note, nobody is going to ask you about category B. It contains all the common diseases like you can read it: brucellosis, psittacosis, Glanders disease, or Escherichia E. coli, typhus, staph, viral encephalitis, cholera, everything. Category A, you should remember: anthrax, botulism, smallpox, plague, tularemia, viral hemorrhagic fever, Ebola, Lyssa viruses. Category C are like hantavirus or the Nipah virus. We don't know where is COVID-19. Till now, it has not been categorized, but I don't know. It could be probably category C, but fingers crossed. I don't know. I'm not commenting anything. For your exam, please note these are the bioterrorism agents, and COVID-19 has not yet been classified as of November, you can say October 2022. Next is this burning topic, that is inferential stats. A lot of this is a guarantee question in your INICET exam. What do you mean by p-values? P-values, please note, if they are less than 0.05, it means that the p-values are significant. What do you mean by significant? That means the effect was observed or not observed. The effect was observed. That means the effect was found if the p-value is less than 0.05. So what do you do about the null hypothesis? Null hypothesis is rejected. So these are 3 words which are going to definitely come in your exam. Next is, a lot of time they also ask you, where does the p-value lie? 0.05. Please note that the p-value 0.05, it lies at 2 SEs, or the standard deviations. So anything which is outside the normal zone, this is what is the normal zone. 95% is the normal zone. Within plus minus 1, 68, plus minus 2 is 95, plus minus 3 is 99. So anything which is within the normal zone, that is normal, that is the p-value which is more than 0.05. If the p-value is less than 0.05, it lies outside the normal zone. Next is, sometimes they ask you how many people are behind 2SD or within 2SD and all that. Please note, if they give you a data like what is the mean, they'll give you some mean and they'll give you some standard deviation. So if you want to find out how many people are more than this, please note my language, more than this. How many people are more than this? If you want to calculate how many people are more than this, then You find out the total. Total is how much? Total out of this is how much? Total is how much? 100. So out of this beta, what you need to do is you take out this 95. Don't think about these decimals. Forget about this 2 and 4 and 7. So forget about this 2, 4, 7. So think about 95. So total is 100. Out of 100, you take out 95. How much is left out? 5%. So out of 5 bache, 5 is 2.5 is left this left side and 2.5 is this side. Don't get confused that 95 sir asked and 5% I thought is more. That is a wrong answer beta. 5% means that 50% is less than this and 50% is more than this. So 50% less than this minus 2 and 50% will be more than minus 2. If they ask you how many people are more than 3, so total is how much? 100. Out of 100 I take out minus is 99. So out of 99 more than 3 pucha. So more than 3, how many people will be more than 3? 99 gone, 1 left, 0.5 more and 0.5 will be less. Do you get this? Simple questions they ask you, and this is very, very frequently asked in your exam regarding inferential statistic. Next is, what is this coefficient of variation? Sometimes they ask you how to find out the variability between sample A and sample B, or the population A and the population B. Simple, very simple. You need to see that is what is the standard deviation and divided by the mean into 100. Please also note that sometimes they ask you about the sampling methods. Beta, sampling methods can be of two types. We can have random sampling or we can have non-random sampling. Random sampling is also called as the probability sampling. Probability sampling. Probability sampling could be like simple random sampling or the simple probability sampling, or we can have stratified sampling. What do you mean by stratified sampling? Where you divide the population into certain groups like upper class, middle class, lower class, educated, uneducated. You divide the population into male, female stratas. You divide into stratas and then you pick up from each strata. So that means that every strata is representing the population. If I want to pick up 50 people for a march past from a medical college for celebrating the Independence Day of India, and we want to do some march past, so I'll take out people who are from good physical health, medium physical health, and not so good physical health. I can also take up people who are average in studies, below average in studies, or above average, so I can stratify. Next is, we can also have a systematic sampling. Systematic means you take out the every fifth person. So all these are probability. Last is, you should also know we can have a cluster sampling. Cluster sampling is never used for surveys. It is always used for evaluation. Cluster is the only one which is used for evaluation of health programs, and cluster sampling, you do it for large homogeneous population. The other sampling method that I was talking is a non-probability sampling. Non-probability sampling is like convenient sampling. You do whatever you want to do. Or you can do a quota sampling, that I will always take these 10% of children who are scoring between this and this, whatever. So that is what is a quota sampling. Or we can have something called as a purposive sampling. I do it with some purpose. Or we can have a snowball sampling. All these are non-probability sampling methods. Coming over to the 17th point, health system update. 17 out of 20 points. So there are some health system updates. What is this NELS? NELS stands for the National Emergency Life Support Training. So beta, very recently the government of India has started the NELS training. So there have been a lot of training protocols regarding the adult, child, infant CPR, AED and the manual defibrillation techniques, cervical spine control, RTA, very important, crucial component is the RTA, bleeding, fracture management, transport of the victim, extraction of the victim from the site, cardiac, surgical, medical, obstetric and the pediatric emergencies. Snake bite protocol, very frequently they might ask you, because snake bite protocol has been developed in 2018-19 by many professors. They contributed to it. So just one point I would say about the snake bite protocol. What is the technique we use for management of snake bite? So for clinical management and resuscitation, we have a CABD approach rather than a traditional ABCD approach. So always in a snake bite, it is more crucial to talk about the circulation, that is the arterial pulse, followed by A, B and D and E. So that is about the snake bite protocol. Snake bite protocol, that is the CABD approach. Next is what is IPHS standards, upgrades and updates. So in IPHS standards, we already know that there is something called as a PHC, subcenters and the CHCs. First important information is that the sub-centers that we were having in India, they have been upgraded to health and wellness centers. What are these health and wellness centers? Beta, health and wellness centers, they have been started under the Ayushman Bharat, where we have a comprehensive primary healthcare system, where we have started with the CHO post. CHO stands for a community health officer, and these are the nursing officers. They are available at our subcenters, and if the CHO is available at a subcenter, we will go to the subcenter and rename the subcenter to a health and wellness centers. Everything else remains same. The PHC on the same manner. PHC, we can have the urban PHCs or the rural PHC. Rural PHC we have for 30,000 population in the plain areas, and the urban PHC are for 50,000 population. As far as the number of beds, this have been a lot of controversial MCQs. The number of beds, please note that the CHCs, community health centers, they are usually 30 bedded in rural areas. CHC. So CHC in rural areas 30 bedded. Now in case the CHC has been upgraded to an FRU. So what is FRU? FRU stands for the first referral unit. So in case the CHC, conventional CHC, which was 30 bedded, it has been upgraded to FRU. It is called as a FRU CHC. It could have up till 50 beds. So whatever number. In case it was an urban CHC, which is for 2.5 lakh in all the cities and for 5 lakh in metropolitan cities. In urban CHCs, minimum number of beds is 50, and in case it has been upgraded to FRU CHC, FRU UCHC, it will be 100 or 100 plus beds. So number of beds in a district hospital, they can range always more than 100. It could be up till 700 or 1000 or even 2000 bedded hospitals we have in India. In Delhi, that is about the district hospitals. Next is nursing staff registry schedule has been started by the Ayushman Bharat. This is to promote the CHO level nursing officers at all the health and wellness centers in India. What is TriHOb? TriHOb stands for the Tribal Health Observatory. Tribal Health Observatory. Tribal Health Observatory. It is for the first time Government of India has started with the TriHOb program. It has started from the state of Odisha, and it is to tackle the tribal health in the state of Odisha. They have also started for the first time Mo School. Mo School is the My School mission, and they are going to take care of the health of the tribal population. Last is the SRS 2022 and the MCCD 2020 updates for you. Please note that the SRS data, which was released May-June 2022, it tells us that the crude birth rate in India is 19.5, the crude death rate is 6.0, and the infant mortality rate is 28, and the under 5 mortality rate is 32. Under 5 mortality rate is 32. The total fertility rate is 2.0. The sex ratio as per the NFHS number 5 is 1020, and the child sex ratio, that is the sex ratio at birth, is 929. So the adult is 1020. That was regarding the numbers. The death rate has been highest in Chhattisgarh, whereas it has been the lowest in Delhi. Please note that the infant mortality rate has been highest in Madhya Pradesh, and the birth rate has been highest in the state of Bihar. Coming over to NFHS, National Family Health Survey. National Family Health Survey was conducted by the International Institute of Population Sciences, IIPS, which is located in Mumbai, Maharashtra. It has 4 parts. 4 parts, these are called as the 4 schedule. In case a person is a male, we give the male schedule, or a female schedule. We also give to both male or female, we also get the biomarker and the household schedule. So there are 4 sections in the NFHS 5. The NFHS 5 released the data like under 5 mortality rates, TFR, sex ratios of India, and it has been worked upon, and it is one of the very beautiful systems that we have. Next is, what about the most common cause of death? This is a controversial question. Please beta try to understand that the most common cause of death as per the medical certificate cause of death, which was released in 2021 October, and it includes the COVID deaths. So the medical certificate cause of death. Now many infants, they don't get a medical certificate done. Many infant deaths. So in case of adults, medical certificate cause of death is more relevant. In case of infants, it's not very relevant. But if you talk about the most common cause of death as per the MCCD 2021 report, As per this report, the most common cause of infant deaths, that is hypoxia, birth asphyxia and other respiratory illnesses, but for infants. But please note, this is for medical certificate cause of death. This is a very special, in case the MCQ directly says MCCD. But if the MCQ does not say anything, please note my words. If the MCQ says most common cause of infant deaths or the neonatal deaths or the under 5 deaths, most common, listen very carefully, most common cause of infant deaths, under 5 deaths or the neonatal deaths. As per the MCCD data, what is your answer? Hypoxia, birth asphyxia in that case. Otherwise, if nothing is said, then your answer is general answer. Sample registration system also says this, that what is the most common cause of infant deaths? Most common cause of infant deaths is low birth weight and prematurity. That is always the answer. If nothing is said, low birth weight, prematurity. If SRS data is saying, again low birth weight, premature. But if the question says MCCD cause of death, medical certificate cause of death, then your answer is hypoxia, birth asphyxia and other respiratory diseases. Please take a note of this. What is the most common cause of child deaths? What do you mean by child deaths? Child death does not mean under 5 deaths. It's death age group of 1 to 4 years. Death of age group 1 to 4 years. What is the most common cause as per the MCCD cause? It is septicemia, beta. Septicemia. AIMS people are known to play with data like these, and that's the reason I'm telling you. I know it may be a burden for you, but if nothing is said, follow the SRS, that is low birth weight, prematurity. That is a general common sense, biologically explainable answer. But if the question says medical certificate cause of death, what is the most common cause of infant deaths? Hypoxia, birth asphyxia. Medical certificate cause of under 5 deaths, then again hypoxia, birth. But if the question says 1 to 4 year age group, what is the cause of death? Then you need to mark the septicemia as the best answer. Point number 18, F plus fortification scheme. What is this F plus? The logo is F plus. Any food which is fortified in India now will have this logo. What is this logo? It is for wheat, flour and the fortified rice kernels. We are triple fortifying them. Iron, folic acid and with vitamin B12. Iron, folic acid and vitamin B12, three elements to be fortified in wheat, flour and the fortified rice. And that is what is the staple diet in India. The milk and the edible oils, they should also be fortified with vitamin A and D. Vitamin A in the dose of 2500 international units, vitamin D as 175 international units per 100 ml of the oil, and this should be with the symbol of F+. Next is double fortified salt. This is also called as a twin fortified salt. It is with iron and iodine both. So that is what is the F+ scheme. Point number 19, what is global genomic surveillance strategy? Global genomic GGSS strategy. So GGS strategy, that is having 5 objectives. That there should be more access to tools for better geographic presentation. That is the reason I had been teaching you about the corplet graphs. So what are corplet graphs? They are for tools for better geographic presentation about the burden or intensity of disease. To strengthen the workforce and to enable data sharing, more GIS softwares, more and data sharing to be happening, maximize connectivity and readiness posture. That is what is the 5 objectives of the global genomic surveillance strategy. It is for 10 years. It was started in year 2022. It will be continuing till 2032. It is a WHO project. It is a project by the World Health Organization. Last in line, India TB report 2022. Just very quick review. What is the strategy that we are still following in TB? We have a detect, treat, prevent and build strategy. The TB preventive treatment, this is something new. This has been updated. TB preventive therapy. We have 2 TB preventive therapies, 6 months of INICET, or we can give. So, and means like the government of India, we have both the options. The person can take any one of them. Either the person can take 6 months of INICET or the person can take 3 months of H and P. What does P stand for? P stands for not pyrazinamide. P stands for rifampicin. Along with INICET, I hope everybody recalls that we are supposed to give the vitamin B6 prophylaxis. The TB India 2022 report, which was based on the 2020 statistics, it says that the TB incidence in India is 188 per lakh population. MDR TB is 4, XDR TB is 1 per lakh population. Number of TB deaths has reduced to 37. there is a considerable 5-point reduction in the number of TB deaths. Recently, in September 2022, we started with the TB Mukt Bharat program. What do we do in TB Mukt Bharat program? We already had been giving the Nikship Poshan Yojana. You remember 500 rupees given per month to all the TB patients. Under the TB Mukt Bharat scheme, now we are giving monthly food basket to improve the nutrition of the TB patients. Now the DMC, you remember what is DMC? Designated Microscopy Center. They have now been renamed to the TB Diagnostic Centers. In TB Diagnostic Centers, we are doing 3 types of case finding: active, passive and intensive. Passive is where the doctor is sitting. Intensified is where you do comorbidity screening. Patient come for diabetes, you check for TB. And active case finding is to be done in all the high risk population. The TB treatment, we have talked about a lot of regimes in our lectures, in our sessions. A very quick review: you should know that there is something called as a drug sensitive TB. What is the regime we give for the drug sensitive TB? We give 2 months of HRZD plus we give 4 months of HRE. What is the drug regime which we give to H. monopolydia TB? H. mono means only isoniazid drug resistant. In only isoniazid drug resistance, we give the zero regime. You can remember this as the zero regime. What is zero? Z stands for pyrazinamide, E is ethambutol, R is rifampicin, O is levofloxacin. O is levofloxacin. O is not ofloxacin, O is levofloxacin. For MDR RRTB or for the XDR-TB, Government of India is proud to say that there is oral shorter MDR RRTB. Earlier there was kanamycin injection. Now kanamycin has been replaced with bedaquiline. So what we are giving in all oral shorter MDR-TB RRTB regime, we are giving Ch.pox. What is Ch.pox? Ch.pox stands for clofazimine, high dose isoniazid, levofloxacin. B stands for bedaquiline, Z is for pyrazinamide, E is ethambutol, E is ethionamide. So these are the Ch.pox regime which we are giving for 4 to 6 months, and then for 5 months we are giving the Co-Z regime. All oral MDR XDR longer regime. Longer regime beta we are giving for 18 to 20 months of C2L2B. C2L2 means cycloserine, clofazimine, L2 is linezolid and levofloxacin, and B is bedaquiline. 18 to 20 months of this. When do you give a shorter and when do you give a longer bedaquiline containing regime? Please note that the shorter is supposed to be given to all cases of MDR where there is only one gene resistance. Either it is INHA gene or it is a CAT gene, but there is only one gene resistance for isoniazid. In those cases, you can give the shorter bedaquiline containing regime. When do you give the longer bedaquiline containing regime? In cases where there is both gene mutations, either INHA and it could be CAT-G gene. For isoniazid I'm talking. So in case there is a 2 gene mutations, you need to give the longer one. In case it is shorter, you can give a trial for the shorter bedaquiline containing regime. And so with that, I'd like to thank you so much for attending this module, and I wish from the core of my heart, I wish all the very best to you. My prayers are that you should get the seat of your choice, work very hard, and make sure you go with a single focus that you are going to clear the exam with the rank of your choice. All the very best and stay focused. God bless you, beta.